Let's talk about bronchial asthma management according to latest GINA guidelines. So it is defined as a chronic respiratory disease characterized by inflammation of small airways leading to episodic or variable airflow limitation, usually due to airway hyperresponsiveness to endogenous or exogenous stimuli. Right. We're going to give emphasis on chronic respiratory disease, and we should remember that it is a type of inflammation of small airways leading to episodic or variable airflow limitation. Right. And it is due to airway hyperresponsiveness, various stimuli. Right. Closest differential of bronchial asthma is the COPD. Right. So both asthma and COPD will have airflow limitation, FEV1 by FVC ratio less than 0.7, which indicates airflow limitation. The difference is improvement of more than or equal to 12% of the FEV1 with a bronchodilator, and less than 12% with the bronchodilator indicates COPD. The symptoms usually are chest tightness, shortness of breath, cough, and wheeze. Usually variable in intensity or episodic in nature in case of asthma, while persistent or gradually progressive in case of COPD. Right. Cough is usually dry and irritating with scanty production in case of asthma, while it is associated with copious mucus expectoration in case of COPD. The management of bronchial asthma is given by the GINA guidelines. The latest guidelines came out in May 2025, and it's valid up to the next guidelines. Guidelines of management of COPD is the GOLD guidelines. The latest being the 2026 guidelines, which came out in November 2025. Right now, the risk factors of bronchial asthma, they can be triggered with some factors. The risk factors can be genetic. Right. Certain genes are implicated, like ADAM33, DPP10, ORMD23, and 5q polymorphism. Right. Next is environmental factors. The most important of all is the hygiene theory, which suggests that children hailing from well-to-do families with proper hygiene have low exposure to environmental antigens, and they are prone to develop bronchial asthma in the later life. Occupational factors like exposure to carbon monoxide, N2O or sulfur dioxide, low birth weight through cesarean section, and exposure to PPI and smoking during pregnancy. Right. Tobacco exposure, infections, either upper respiratory tract infection or lower respiratory tract infections. Reactive airway, if the person is obese, they have increased levels of adipokines and IL-6, which are implicated in the development of asthma, atopy, and dietary factor, less omega-3 fatty acids, less amount of vitamin A, C, D, less amount of magnesium, and more amount of sodium. These factors are being implicated as risk factors. Now, on top of this, if the patient is prone to have asthma, certain triggers are there which can cause exacerbations in between. First one is wind or cold air. In the latest guidelines, cold air exposure is being emphasized as an important factor to cause trigger. Right. Then we have allergens. Common allergens include dust mite, then paint furs, paint fumes, tobacco smoke, cockroach droppings, pollens, etc. GERD, gastroesophageal reflux disease, emotions, including anxiety, excessive laughter. We have stress, either mental stress or physical stress, pregnancy, allergic bronchitis, or viral upper respiratory tract infection, irritants, and drugs. Drugs include aspirin, ACE inhibitors, adenosine, and beta blockers. Right. This can be remembered as get in road, and these triggers can be remembered as wages paid. So let's talk about types of asthma. According to the triggers, atopic type or extrinsic type, where the trigger is an extrinsic factor, and we have intrinsic type. Right. This is often associated with allergic reactions. Is not usually associated with allergy. Triggers will be allergens, and in here, triggers will be usually infections. Right. In here, IgE level will be increased and it will be normal in the intrinsic type. There could be family history of allergy, while it's not significant over here. Onset is usually childhood, extrinsic, and intrinsic type is usually started in adulthood. Males are seen more dominant in extrinsic type, while intrinsic type has male equal to females. Prognosis and response to treatment is pretty good in atopic type, while it's poor in intrinsic type. Now this extrinsic type, we find that the mediator helper T cell is Th2 in this type of asthma. That's why this type of asthma is also known as type 2 bronchial asthma. And in here, Th1 and Th17 are seen to be involved. We don't call this type 1 or type 17, but we call it as non-type 2 bronchial asthma. Right. Now, let's discuss about the cytokines involved. So it is this Th2 which sends signals through IL-4, IL-5, IL-13, and IgE. IL-4 is supposed to stimulate the B cells, which in turn will secrete IgE. Right. And IL-5 will activate 1, 2, 3, 4, 5 eosinophils, and IL-13 will activate the goblet cells, which will cause increased mucus production. Right. In here, in non-type 2, the cytokines involved usually are IL-1, IL-6, IL-17, and interferon gamma. Right. Now, the effector cells, of course, will be the eosinophils and the mast cells. So these eosinophils will cause hypertrophy and hyperplasia of smooth muscle cells in the respiratory system, while the mast cells will produce histamine, leukotrienes, and prostaglandins, which will cause bronchoconstriction airway edema, and increased mucus layer. Effector cells in case of intrinsic or non-type 2 bronchial asthma is neutrophils. Biomarkers: eosinophil count would be more than 300 in this type. There will be increased IgE levels, usually more than 500, and there is something known as FeNO, fraction of nitric oxide in the expired air, which will also be increased in type 2 bronchial asthma. And these things will be pretty much normal in non-type 2 bronchial asthma. Response to steroids and other treatments would be sensitive over here, and they'll be poor or resistant in non-type 2. Right. So this outline is very important in as in line of pathogenesis and in line of the certain biologics which we will discuss later. Here, let us remind ourselves that bronchial asthma, it's a type 1 and type 4 hypersensitivity reaction. Right. This has nothing to do with type 2 asthma or non-type 2 asthma. Right. Any lung disease, either obstructive lung disease or the restrictive lung disease type, if they remain unchecked chronically, they can cause increased pulmonary hypertension, which will lead to right heart failure. Right. This right heart failure, because of a chronic respiratory illness, is known as cor pulmonale. So we want to prevent this. Right. Now let's talk about the investigative workup. First of all, we want to do one spirometry. Right. Spirometry is the investigation of choice. Right. The first thing we want to look at is the FEV1 by FVC ratio. If it is less than 0.7, this is indicative of airflow limitation. Right. Now we will record the FEV1. Right. Now we will give salbutamol MDI 2 puffs and repeat the spirometry after 15 to 20 minutes, and we'll figure out the FEV1 improvement from the previous FEV1 more than or equal to 12% or more than or equal to 200 ml. This suggests bronchial asthma. If not so, this suggests COPD. In case we don't have the facility of spirometry, we can do PEF with the peak flow meter. If this improves with the salbutamol by more than 20% in adults and more than 15% in children, this is bronchial asthma. Right. And this is known as bronchodilator reversibility test. Right. We also like to look at the CBC, especially if the eosinophil count is more than 300. It is indicative of type 2 bronchial asthma, and if it is less than this, it is suggestive of non-type 2 bronchial asthma. We want to look at the total IgE levels as well. In type 2, it is supposed to be more than 500 at least. Right. If total IgE is more than 1000, we need to rule out allergic bronchopulmonary aspergillosis as well, which is an important mimic of resistant type of bronchial asthma. Fraction of nitric oxide in exhaled air, which will also be increased in type 2 bronchial asthma. Right. Suppose none of these above tests are grossly positive, and if there is strong suspicion of bronchial asthma, we can do one provocative test as well, as spirometry can be normal in baseline normal conditions in asthmatic patients as well. So we need to activate the asthma cascade by giving some provocative test. First of all, we can give methacholine. By giving methacholine, if the FEV1 decreases by more than or equal to 20% from the previous FEV1, this is suggestive of bronchial asthma. Right. If methacholine is not available, we can do with certain other things like 3% saline, mannitol, histamine, or stress test or exercise or exposure to cold air. After provocation with these agents, if there is decrease of FEV1 by more than or equal to 10%, right, this is also suggestive of bronchial asthma. Now we have allergy test as well. Could be either specific IgE allergy panel or the RAST, which stands for radio allergo sorbent test, right? So these are the investigations we want to do in a suspected asthmatic patient. Apart from this, we want to do one chest x-ray. Mind you that chest x-ray has nothing to do with asthma, but it helps to rule out other differentials, right? Then we can do HRCT chest if there is any suspicion of any pathology. We can do ABG if we suspect of CO2 retention or hypoxemia. We can do DLCO. Usually it is normal or slightly increased in bronchial asthma, and this increased DLCO in asthma is because of increased vascularity in inflammation, as asthma is a inflammatory disease. But we usually do not do this test. X-ray we usually do. Now let's discuss about the treatment options we have in hand. First of all, we have the bronchodilators, which is the mainstay of asthma management. Bronchodilators are either sympathomimetics or beta agonist, or could be parasympatholytics, also known as anti-muscarinics or muscarinic receptor antagonists. Beta agonist, we have short-acting beta agonist. The best example is salbutamol, albuterol, terbutaline, right? In long-acting beta agonist, we have two things. First one is formoterol, which is fast-acting. F stands for fast and long-acting. The other one is salmeterol, which is long-acting but having slow onset. I want to emphasize on formoterol here, as it is having a faster onset, just like SABA, and a longer action, as it is a LABA. This is the preferred treatment in the latest guidelines, right? Muscarinic antagonist, we have SAMA, LAMA, long-acting muscarinic antagonist. Examples include tiotropium. In SAMA, we have ipratropium and glycopyrronium. So side effects of beta agonists include tachycardia, tremors if used excessively, hypokalemia, palpitation, and mild hyperglycemia, right? And side effects of muscarinic antagonists include dry mouth, and this is also termed as atropinization. If we use the bronchodilator to relieve acute attacks, the therapy is known as reliever therapy. The reliever therapy is to treat or relieve acute attacks. So reliever therapy can be either SABA or SAMA or a faster onset LABA. So formoterol. is the one we're talking about. Right. Maintenance therapy is the therapy which is being used to control or prevent future attacks. Right. This used to be called as controller in older guidelines. Nowadays, it is termed as maintenance therapy, as it maintains stability to the asthmatic patients. It can be done by any LABA, which can act throughout the day. Right. And an ICS is usually added, inhalational corticosteroid therapy. Nowadays, the preferred maintenance is formoterol. Right. Now, as we're discussing about formoterol, we know that it is a LABA with fast onset. So it can be used as maintenance as well as a reliever therapy, as it is fast in onset. So using only the formoterol ICS is now called as maintenance and reliever therapy MART. So this can be used as maintenance, as well as if exacerbations happen in between, we can use this SOS additionally. Right. And a new point is that SABA or salbutamol should not be used alone, as it increases mortality. If we want to use a SABA, we should always combine with something else like steroid or a LAMA or SAMA. Formoterol is the preferred treatment nowadays. Its low dose is 6 micrograms and medium dose is 12 micrograms. Now let's talk about certain add-on maintenance therapy. First thing is steroids. Steroids, we want to give it as inhaled corticosteroid. Examples include budesonide, beclomethasone, fluticasone, and mometasone as well. There's orals. Examples include methylprednisolone or prednisolone, dexamethasone, and hydrocortisone. If it is an acute severe exacerbation, we can give IV hydrocort, dexamethasone, or methylprednisolone. Side effects of steroid, as we all know, that they cause gastritis, osteoporosis, and steroid dependence. So we should always prescribe a PPI, calcium, and we should also try to taper down the dose before stopping it abruptly to prevent steroid withdrawal. It also causes flaring up of any infections, so we should rule out any active infection before giving steroids. The next add-on therapy is leukotriene modifiers. This decreases airway hyperresponsiveness. Right. And here we have the leukotriene receptor antagonist. Examples include montelukast, which is widely used nowadays, and also there is this zafirlukast. We also have leukotriene synthesis inhibitor. Example is zilutone. Note the side effects of leukotriene modifiers, especially there is suicidal tendency and depression if used for prolonged period of time. The next thing is mast cell stabilizers. They decrease degranulation from the mast cells. Examples include chromoline sodium. The last, we have xanthin derivatives. These are non-selective phosphodiesterase inhibitors because increased cyclic AMP and cause bronchodilation. Examples include theophylline, etophylline, aminophylline, which is theophylline plus etophylline combination, comes as dairyphylline injection. It's very widely available and cheap, actually prone to cause palpitations and arrhythmias, and they have narrow therapeutic margin or safety margin, so their use is currently discouraged by the latest guidelines. Acebrophylline, which comes as 100 to 200 milligram tablets to be used twice a day, or doxophylline injections, which comes as 400 milligram injections. They are comparatively safer. The targeted therapies, also known as the biologics. First is the anti-IgE. Example include omalizumab. Next is anti-IL-4 and it has action also against IL-13. As it is acting in two things, we can remember it as dupilumab, right? And we have anti-IL-5 receptors, which bans the receptor of IL-5. So it is ban receptor benralizumab, right? Then we have anti-IL-5 antibodies. We have two of them. First one is the mepolizumab, and the last one is the raclizumab. The first four are given through subcutaneous route, and the last one, raclizumab, is given IV. And all of these five are directed for type 2 bronchial asthma because these receptors and the interleukins are involved in type 2 pathology. Benralizumab is approved for children above 12 years, mepolizumab above 6 years, and raclizumab above 18 years. Now, for non-type 2 bronchial asthma, we have one biologic, which is anti-TSLP or thymocyte stromal lymphopoietin. The only example is tozepilumab, and this is for non-type 2 bronchial asthma. If the patient is not improving with all these measures, we can counsel them for a last resort, which is bronchial thermoplasty. Mind you that the most common cause of difficult to treat asthma is faulty technique of inhalation, right? And the second most common is obesity. So we want to advise the patients that their weight should be maintained, and despite correction of the technique of inhalation and reducing body weight, if the patient remains refractory, those patients will be called as refractory asthma, despite maximal treatment modalities. So this is the last option. In here, we will bronchodilate the patient adequately, and we will insert a USG thermoprobe, which is inserted bronchoscopically. This produces heat inside, causing coagulation or denaturation of the proteins involved in the bronchial walls. And these proteins will be, as they are denatured and coagulated, they will remain fixed, and the bronchi will be fixed and dilated. They will remain dilated permanently. So this is how it works. Let's discuss about certain variants of asthma. First, we have this EIBA, which stands for exercise-induced bronchial asthma. Then we have aspirin exacerbant respiratory disease. This is actually a case of aspirin intolerance. Then we have cough variant asthma, which present with dry cough. And we have nocturnal asthma, which present in the nights basically. And we have brittle asthma, which is a type of asthma in which severe sudden attacks usually happen recurrently. And we have asthma COPD overlap. Asthma COPD overlap is suspected in young patients less than 40 years of age presenting with COPD. There is something known as Samter's triad, which is repeatedly asked in entrance exams. So it has three components. First one is aspirin intolerance, nasal polyps or sinusitis. Then we have this asthma, which is usually of non-type 2. So this is Samter's triad.